Hi, my name is Michael Wallace. I'm a professor of medicine and gastroenterology at the Mayo Clinic in Jacksonville, Florida. It's my pleasure today to present our study, which will also be published in Gastrointestinal Endoscopy. We conducted a study titled The Effect of an Endoscopic Quality Improvement Program on Adenoma Detection Rates, a multicenter, cluster-randomized controlled trial in clinical practice. Why did we do this study? This is actually an ongoing series of trials that we have termed the EQUIP studies, and EQUIP stands for Endoscopic Quality Improvement Program. Our main goal has been to improve the quality of colonoscopy, typically as measured by adenoma detection. In two previous trials, we performed initially an uncontrolled cohort study, and that was followed by a single-center randomized controlled trial at the Mayo Clinic in Florida. And those studies both showed that a quality improvement intervention, largely an educational program and a monitoring and feedback program, improved adenoma detection rates significantly in a single-center practice. Our goal in this study was to see if the same quality improvement intervention could improve adenoma detection rates on a larger scale, and particularly in a clinical practice setting outside of an academic environment. To do this, we partnered with the GI Quick and the American College of Gastroenterology to measure adenoma detection rates in 9 centers in the United States. These were large ambulatory surgical centers, each one performing at least 500 colonoscopies per month, typically much more than that. And when we gathered the data for these, at first we asked each of these 9 centers if they would agree to participation. None of them had previously employed a structured quality improvement program. If they agreed, we then signed them up for the GI Quick monitoring system, and for approximately 6 months, we simply monitored their baseline adenoma detection rate. At that point, we then randomized half of the centers, or in this case 5 of the centers, to receive a quality improvement intervention, and the other centers, the remaining 4, continued to practice as they were without any specific quality improvement intervention. And I should also mention that neither group received any feedback on their adenoma detection rates at this point in the study. So there was no feedback and no specific quality intervention during the baseline period. The 5 centers that were randomized to receive the quality improvement intervention then underwent an educational program. We visited each of these sites. We met with the leadership of the group, also with the nursing leadership of the group to review their current practices. We reviewed their current adenoma detection rates, their scheduling practices, how long they were allowed to perform colonoscopies, their bowel preparation regimen, and also reviewed methods how they could improve their adenoma detection rate, such as careful washing of the colon, tip deflection behind folds, and allowing adequate time, at least 6 to 7 minutes during the withdrawal phase of the colonoscopy, to inspect for adenomas. We also provided each group and each individual with their own adenoma detection rates, as well as other important quality measures, such as cecal intubation rates, withdrawal time, and bowel preparation quality. At that point, we monitored actively in both arms. The intervention arm continued to receive monitoring and receive regular feedback approximately monthly. They received their adenoma detection rate data at least monthly. We also placed posters on the wall of their endoscopy rooms to show them images of flat or difficult to see polyps and to reinforce the educational methods that were administered during the active intervention. The other control sites, as I mentioned, continued to practice as they were before. They received none of those interventions and did not receive feedback on their adenoma detection rates until the very end of the study. The results of the study were quite important and to some degree a little bit surprising. In the end, we randomized approximately 22,000 colonoscopies, approximately half of those in the intervention arm and the other half in the control arm. We did see in the control centers an increase in the adenoma detection rate from the baseline data to the follow-up data after the intervention. The odds of increasing the ADR, or the odds of finding at least one adenoma detection rate, increased by an odds ratio of 1.28, or there was approximately a 28% increase in the odds of finding an adenoma. This in raw numbers corresponded to an adenoma detection rate at baseline of 31%, which increased to 42% after the intervention. We also, in the control arm, saw a slight increase in the adenoma detection rate, although it was not statistically significant. The raw adenoma detection rate at the baseline was 36% at the control site, and that increased to 39% after in the second phase, after they were monitored in the second half of the study, but without an intervention. What was surprising is that the difference between the intervention sites and the control sites was not significant. So although we saw a statistically significant increase in ADR in the control sites, that a statistically significant increase in the ADR in the intervention sites, we also saw that small increase in ADR in the control site. So the difference between the two did not reach statistical significance. So in the end, we felt that both sites had slight increases in their adenoma detection. Why we did not observe a significant difference in the two is an area of speculation. We did look at some other important outcomes. For example, we looked at the increase in detection of advanced adenomas, and this was also only very slight and not significant. And as with other studies, we did see higher adenoma detection in patients who were suspected to be at higher risk. For example, surveillance patients had an ADR of about 43%, whereas screening patients, their ADR was 28%. As with other studies, men had higher adenoma prevalence than women, at 37% for men versus 26% for women. So those are the main results of the study. How do we interpret these results? Well, first of all, we did see an increase in both arms of the study, albeit a significant increase in the intervention arm and a non-significant increase in the control arm. We largely think that this effect is likely due to a so-called Hawthorne effect. Hawthorne refers to the phenomenon where when someone is aware that they're being monitored, their behavior changes. And we know from other studies that simply telling someone that their adenoma detection rate is being monitored, either by a data system like GI Quick or a video recording system, we know that their adenoma detection rate actually tends to increase without any other intervention other than just knowing they're being watched. And so we suspect, or at least speculate, that the increase that we saw in the control arm may be due to a Hawthorne effect. And thus the greater change that we saw in the treatment arm was diluted by the weak change in the control arm. I think the good news from this study is that we saw increases in adenoma detection in both groups. And so simply participating in a program that monitors adenoma detection, being aware that your adenomas are being monitored, that your adenoma detection rate is being monitored, does lead to some increase in overall quality of colonoscopy, albeit a smaller increase than we expected. I think going forward, we still believe, based on all of the EQUIP trials that we've done now, including this one, that this is a beneficial program to increase adenoma detection. We're partnering with the GI Quick group to implement this on a more wide scale. We've also partnered with several other organizations in the United States and elsewhere to apply this intervention to improve ADR throughout the United States and beyond. I do want to make one additional comment just about this paper and this journal. As you may know, I'm the editor for Gastrointestinal Endoscopy, and as an author submitting a paper, it's important that we manage those conflicts of interest. So in cases like this where I or any of our associate editors submit papers to Gastrointestinal Endoscopy, those papers are reviewed and the decisions made by an independent editorial board that only reports directly to the ASG governing board. And in that way, we can minimize some of those conflicts of interest. Nonetheless, it's a pleasure to publish it in what I think is the leading journal of endoscopy in the world. And perhaps I'm a little bit biased, but we're very proud to see our paper published in GIE. Thank you very much.